Welcome to Biomechanics Module 1. So we're going to do some introductory terms and definitions. Some of you may have had all of this before, but we want you to hear the message again and start to think about it more through a PT student and a PT clinician lens. So we are the movement experts. We're going to talk about movement in two ways. One is kinematics, and those are motion without thinking about forces. And there are two main types of motion: linear motion and angular motion. And we use some descriptors when we talk about these types of motions. We talk about things like position. What position is the arm in, or the leg in, or the knee joint? Displacement, how far has it moved? Velocity, what's the speed of that motion? And acceleration, what's the change in velocity of that particular motion? So kinematics, movement without thinking about the forces. The second branch is kinetics, and in this case we're talking about the forces and how they impact movement and impact the tissues of the body. We'll talk about things like force and torque. We'll talk about segments that are moving and mass of those segments. And we'll briefly review Newton's laws. There are three of them: the law of inertia, the law of balanced pairs, and the law of acceleration. And I said those out of order. That was law 1, 3, and 2 in my the way I described them. So some basic terminology, and you will have this in anatomy. You might have already heard it in anatomy. So we're going to be speaking the same language as we talk through these things. For anatomy, it's more about relative position and orientation of things. Here we're using it more to describe movements and where movement is happening and how it's happening. So one of the foundational constructs is anatomical position. Again, you'll learn about that in anatomy. This person, this character is standing in anatomical position, looking straight ahead, arms at the sides and palms facing forward. So you'll notice that the thumbs are oriented laterally in each of these pictures. We have three planes of motion that we'll talk about. They're the cardinal planes. You'll hear that term used. And there are three of them. There's a sagittal plane that essentially bisects our body into right and left halves. There's the coronal plane through the crown. Sometimes you'll hear that called the frontal plane, and that's dividing into the front and back halves. And then the transverse plane is a horizontal plane dividing the body into superior and inferior. Now I've simplified and talked about these as sort of two halves, depending on which plane. But really we can shift these planes up and down. So if you notice the transverse plane here on the far right of the screen, we could move that plane up to the head and talk about head rotation or cervical spine rotation in the transverse plane. So it doesn't it makes it easier to describe some of our motions if we can think about moving this plane left or right, superior or inferior, dorsal and caudal, those types of things. Axis of rotation, you'll notice some lines here that go along with the planes. When we talk about movement, kinematics, we'll talk about motion in a plane. And so in the sagittal plane, most of our movements are flexion and extension. We're going to move within that plane, and here again that concept of moving the plane might help us understand this. When we're flexing and extending our arm at our shoulder joint, we could move that sagittal plane out to the glenohumeral joint and think about movement occurring in that plane. The point about axes that are really important is that because these are joint rotations, they're occurring within the joint, and they have to occur around an axis of rotation. Right? You think about a bike tire, it's got an axis of rotation. Anything that rotates has an axis. So our joints have an axis of rotation. When we're describing motion, that axis of rotation is always perpendicular to the plane that we're moving in. So if you're looking at the sagittal plane here, we're oriented, cutting the body into a right and a left side. That means the axis is directed medially laterally. Okay. For the coronal plane, which is oriented, cutting our body into a front and back half, that means the axis has to be oriented anterior-posterior direction. And then for the transverse or horizontal plane axis, the axis has got to be superior and inferior in orientation. Naming conventions, I got into that a little bit, but motion in the transverse, in the sagittal plane is typically flexion or extension. Motion in the coronal plane is typically abduction or adduction. And motion in the transverse plane is usually an axial rotation, a medial or a lateral rotation. Osteokinematics. Osteo is bone, kinematics is motion. So when we use the term osteokinematics, we're talking about a single segment, like the arm or the humerus, that is moving in a plane. We like to think about that moving segment relative to a fixed segment to simplify it. That's not always how the body works, because sometimes that second fixed segment isn't really fixed. But we'll get into that in more detail in biomechanics, which starts in your winter term. But osteokinematics is one segment moving relative to another segment. So a joint rotation that's happening in a cardinal plane is an osteokinematic motion. We've got an axis of rotation going through that joint that is perpendicular to the plane of motion. And this is an important thing that you should start to orient yourself to when we think about the location of that axis of rotation, that hypothetical single axis. It's typically located in the convex shaped bone. So when we've got joint motion, we typically have a concave surface and a convex surface, or a rounded surface. And the axis of rotation is usually through the convex shaped bone. We'll start to draw some pictures of these motions, and that's one of the very first things you can do to help you understand how these systems are working, is to locate that axis in the right location. Okay, so joints come in all different shapes, sizes, configurations, and we've talked about 3 cardinal planes, and there are some joints that can rotate in all 3 planes. The glenohumeral joint is a great example. But there are some joints that can only rotate in 2 planes, and some that can only rotate in 1 plane. The structure of that joint, the way it's put together, the morphology of that joint, dictates how it moves. So sometimes it's constrained in one direction because of the way the joint is configured. We use the term degrees of freedom to talk about how many different planes a joint can move in. So our glenohumeral joint is a ball and socket joint, and we have 3 degrees of freedom at that glenohumeral joint. I've got some examples on the next page, so let's look at those. Okay. On the left of your screen is the humero-ulnar joint. And so that humero-ulnar joint, which is right here, is a hinge joint. So think about a hinge on a door. That has only 1 degree of freedom. We can only flex and extend our humero-ulnar joint. So that gives that joint 1 degree of freedom. Our radiocarpal joint, this is our distal radius. These are our carpal bones in our wrist. That's an ellipsoid joint. It's concave and convex, but it has an oblong shape, an oval shape, kind of like an egg. And so it allows rotations in 2 planes, but it doesn't allow axial rotation. So there's no third motion available at that radiocarpal joint. And then, as I mentioned before, the glenohumeral joint is a great example of a ball and socket joint, and that has 3 degrees of freedom because we can rotate in all 3 of the cardinal planes. This would be a repeat. I've already talked about this, but some of the naming conventions we use: flexion extension, we're moving in the sagittal plane. The axis is then oriented medial and lateral. Flexion describes the angle as decreasing in quantity or in magnitude. An extension usually means that angle is increasing in magnitude. For abduction and adduction, we're moving in the frontal plane or the coronal plane. The axis is oriented now anterior-posterior direction. Abduction, abduction, is moving away from midline, so the midline of the body. And then adduction is moving back towards the midline. And then for the transverse plane motions, those rotations, we term those medial and lateral rotation. Sometimes you'll hear long axis rotation. That'll be some nuance that we'll figure out as we go. But these rotations happen in the transverse plane. That means that their axis is oriented superior and inferior. When we talk about medial rotation, we're moving towards midline, towards the body, and lateral is moving away from midline or away from the body. In this class, Fundamentals of Clinical Biomechanics, we're going to mostly work on measuring range of motion and muscle strength. And so one of the reasons we're teaching these basic concepts is to get us oriented into how those might apply to what we do in practice, right? So when we measure somebody's range of motion with a tool called a goniometer, we're quantifying their osteokinematic motion. How much movement is there available at this joint? So in this class, we're going to determine the amount of humero-ulnar flexion and extension that somebody has, or glenohumeral elevation, abduction, and adduction. I'm going to try to use the right terms. A goniometer is a single plane tool, so we can only measure motion 1 plane at a time, and we palpate to find anatomical landmarks. I will see you in palpation lab for anatomy, so we're going to work on finding the right anatomical landmarks to use. It's really important. We want to position that goniometer correctly, and we need to stay in the right plane of motion. We want to move the goniometer and the joint and segment in the same plane so that we get accurate measurements. And we can do this both during active motion, the patient or the person is moving the joint themselves, or we can also assist and move them ourselves and determine what's the end of their passive range of motion. So we've talked about osteokinematics. Those are the bone motions, segments motion. All right. Now we're going to talk about arthrokinematics, and these are joint motions. So this is what's happening between the two joint surfaces as the segment is going through an osteokinematic motion. These are joint surface motions that happen naturally. We don't think about them, but they're needed, and they happen for a lot of reasons. The joint configuration, the location of the muscles, the soft tissues around the joint that are restricting motions and guiding motions. So there's a lot of reasons why how these things happen, but they occur naturally. And a lot of what happens is dictated by the shape of the two joint surfaces. So we've talked about sort of this ball and socket joint, right? So we can get a lot of movements here. We can get sliding and gliding and rolling. Plane joints, we get just sliding or translations. So introduction to what you'll be learning as you progress through these courses. These arthrokinematic motions can sometimes be created by forces. So if I push on a segment with an external force, my hands, I can create sliding and gliding at a joint surface. Those are often called translations. Sometimes if you contract a muscle isometrically, you can get a joint to translate a little bit. And we'll talk about those as happening, those translations happen either within a plane or along an axis. Those are two different ways to describe these translations. So these are arthrokinematics. Let's get into the types of arthrokinematics that we'll see and need to know. The first one is roll. And so if we have a rounded surface or a convex surface and a concave surface, we can roll like a tire rolling on pavement between those two joint surfaces. So here's rolling a boulder up a hill, right? That's roll. A conception that we need to also keep in mind is that at a joint, both segments, both sides of that joint could be the moving segment. So at the humerus and humeral ulnar joint, it could be my forearm that's moving, or my forearm could be stable, and it could be my humerus that's moving. If you think of a push-up, for example, I'm locked on the floor, my forearm isn't going to move much, but my humerus is moving over the top of that fixed ulna. So in one case, we've got the convex surface moving, and in the other case, we've got the concave surface moving. So these arthrokinematics can take place two different ways in some cases. So roll is a pretty basic one. Gliding and sliding is what it sounds like. Think about a tire that locks up their brakes and they slide on the ice. Or this particular picture might be hard to see, but it's tubing on a frozen surface here. Looks kind of fun. All right, so we call that glide or slide. Spin is the third kind of motion that we describe, and this could be two different ways, and there we'll talk about as we get into the specific joints, you'll learn about which type of spin is happening. But the first one would be like a top spinning on a table, right? So spinning one point of contact of the top is spinning on the second point of contact, the table, right? So that's one way. The other spin would be, think about a tire that's on ice, and now it's not locked up, but it's spinning, right? It's the car is stuck in the snow, and you're trying to get it to free up, and the tire is just spinning there because it's on ice. So that's another type of spin that you'll see. And then what's typical in the body is that you get a combination of these two motions, and usually it's roll and glide happening together. And so this happens, for the most part, the reason we get roll and glide together is to allow us much more range of motion than we would get if we didn't have them happen together. And the glenohumeral joint's a great example of that, and we'll cover that in a class activity. Here's another picture that's just to conceptualize how this might work with spin, roll, and glide. When we describe these things, and this is important for communicating with our peers, communicating on assignments, communicating with other therapists and other providers, we talk about them in the plane or the axis, but then we describe the roll and the glide in the direction in which they're occurring. So when we talk in this example, we've got a picture here of the humeral head, and we've got the glenoid. Okay, so we've got a convex on concave, all right? And we're raising the arm in the coronal plane, frontal plane, and our axis is this blue point here. The axis is directed in an anterior and posterior direction. So this slice is a slice of a coronal plane slice right through the glenohumeral joint as somebody is raising their arm overhead. I'm going to erase these things here. But now what you'll see here in this picture, during abduction, osteokinematic motion is raising the arm up and overhead. The humeral head is rolling superiorly, so that's this blank. The humerus is rolling superiorly on the glenoid, right? The car is driving upward and rolling superiorly on the glenoid, and it's sliding or gliding inferiorly in the opposite direction. So these two arrows are important to be able to conceptualize and draw. Oftentimes I'll do this with my hands. It helps me kind of get a 3D model of what's happening. Some people like to do a little fingertip thing, fingertip in the joint, two joint surfaces. So there are several ways in which you can help yourself work through these. And again, we're going to do some of this in class. So we would call during abduction, we've got glenohumeral joint, superior roll, inferior glide. Because these things typically occur in combination, there's a rule we use to know the directions that these things are going. Like, how do we draw these arrows? How do I describe superior, inferior, medial, lateral? I don't know, right? So there's a rule. It's called the concave-convex rule. And this is the rule. If it is the concave surface, the rounded surface, that's moving on the convex surface, the roll and the glide are going to occur in the same direction. This is a diagram of a sequence of knee extension. Starting with the knee, you're standing up, and think of your knee flex, so your foot is off the ground behind you at 90 degrees in this first position. Okay, so that's your leg. Okay, as you bring your foot down to the ground, it's your tibia that's moving on your fixed femur. So you've got a concave surface that's moving on a convex surface, and those two directions are going to occur those two arthrokinematic directions are going to occur in the same direction. So we're going to do an anterior roll, and we're going to do an anterior slide at the same time. These pictures, this picture and this picture, are from your Newman text, and Newman's got great graphics. I would highly recommend you take a good look at those and study those. They're really informative. Okay, the flip side of that rule is, and we've seen this already in the glenohumeral joint, if the convex surface, the rounded surface, is moving on the concave surface, the roll and the glide are going to occur in opposite directions. So we're abducting, we're rolling superior, and we're gliding inferior. An application of this that we have to understand for when we start treating people and we're choosing interventions is this idea behind an open and a closed chain exercise. And an open chain, or an open kinetic chain, means that the distal end of the segment, in this case the distal end of the leg, let's go purple, right? So this person is moving their leg into extension at their knee joint. Because their foot is free to move, that's an open kinetic chain motion or exercise. So we could load up his ankle with some ankle weights, and this would be a quadriceps exercise because the quadriceps are working to extend the knee up to a straight leg position. All right. A closed kinetic chain means that the foot is now fixed to the floor, and the motion is going to happen top down, right? So the knee is now moving into a flex position. Let me start over. From here, she's already descended to this position. Now she's gonna push up and extend her knee again. He's doing knee extension. She's going to do knee extension. But now it's the femur moving on top of the tibia. Still a quadriceps exercise because the quadriceps are knee extensors. And we have different reasons for choosing an open kinetic chain versus a closed kinetic chain exercise. And we'll talk about those in our therapeutic exercise course. And final slide. Why do we care about arthrokinematics? Well, there's a lot of reasons. One of them is to understand just how healthy a joint is. If we're seeing someone who doesn't have full knee extension, for example, they can't get to 0 degrees of knee extension, which is normal. Let's say they're lacking 10 degrees. We can try to understand, is that an arthrokinematic problem? Do they not have the right amount of glide to get to that end range of knee extension? Do they not have the right amount of roll? And is there a way that we can treat them so that we free up that arthrokinematic motion? We also will talk about something called joint play, and this is in a passive, a joint that is no muscle contraction, it's relaxed. We can use our hands to assess arthrokinematics. So we can find out how much motion, how much translation is there passively in that joint. And you'll do this at multiple joints in multiple classes as you go through the program. Very importantly, joint mobilization is a manual technique that we use to increase joint motion, and we'll push on a segment near a joint to try to free up and increase range of motion. And we need to do that in the right direction. It's typically trying to improve a glide, and so for knee extension, we have to know which direction we should glide the tibia in an open chain or a closed chain. Should we glide it anteriorly? Should we glide it posteriorly? And so understanding the correct arthrokinematics dictates how we do that intervention. And then thinking about arthrokinematics in terms of injury, hypermobility means there's really excessive joint motion that shouldn't be happening, and that's we can think about that sort of conceptually as a increase in arthrokinematics or increase in joint translations, glides, too much glide, too much slide, or hypomobility means there's not enough, right? So there's some injury ramifications for arthrokinematics as well.